How's it going, guys? We have a medium difficulty question for neuro. If you've been following my content, you'll think this question's super easy. That's great, because you've been following my content. All right, so 48-year-old dude, he has a subarachnoid hemorrhage, worst headache of his life, and non-contrast CT of the head, which we do for bleeding, shows brightness, hyperdensity in the basal cisterns, buzzy location, they'll mention in vignettes for the collection of blood. So we're not trying to obfuscate or make confusing the diagnosis. Obviously, it's a subarachnoid hemorrhage, and hypertension is the biggest risk factor. You got to know that. Don't be that person who says ADPKD or Ehlers-Danlos as the first things for subarachnoid hemorrhage. Hypertension is by far the most common risk factor in the population, okay? However, USMLE can be tricky. If they give you a patient who has hypertension, and they say, which of the following are they most likely to die from? The answer is MI, not subarachnoid hemorrhage. Okay, because of atherosclerosis. However, if we do the reverse, where a patient has a subarachnoid hemorrhage, we say, what did they most likely have? The answer is hypertension. Fine. Now, in terms of which vessel is messed up, which vessel was affected, saccular barrier aneurysm, circle of Willis, it's going to be the ACOM or the PCOM, okay, the communicating arteries. ACOM occurs more often than PCOM. The correct answer in here is PCOM, posterior communicating artery. Why? Okay. It's because we have an ipsilateral mydriasis. You need to know that a PCOM aneurysm specifically causes an ipsilateral blown pupil due to compression of oculomotor nerve, cranial nerve 3. The parasympathetic fibers are peripheral around the circumference of CN3, and that'll decrease efferent parasympathetic outflow to the pupil, decreasing pupillary constriction. So you get an ipsilateral blown pupil, mydriasis. The inner fibers of CN3 are more motor control, where if you have a greater degree of compression, you can get partial ptosis, you can get a down and out pupil for extraocular muscle dysfunction. So ACOM aneurysms don't present like that. And it's not a big deal, but it shows up across NBME exams, and they expect you to know that PCOM aneurysm can present this way, all right? So let's just quickly whip through the others to tell you the basic points, make sure you pass. Anterior cerebral artery choice A is wrong. If you have a stroke, a lesion here, you're gonna get contralateral leg findings. So contralateral motor sensory abnormalities in the leg. Okay. Middle cerebral, you're going to have contralateral face and arm findings. Can't screw that up. The MCA has a few more details. If you have a dominant MCA infarct, which is usually the left side in most patients, you can get the aphasia syndromes, Broca, Wernicke, etc. If you have a non-dominant MCA infarct, usually the right side in most patients, that's hemi-neglect. That's an ability to draw the clock pace. And then the PCA, posterior cerebral artery, there's two things you gotta know. One, first of all, it's the occipital lesion that's gonna result in, but the two main things are you're gonna get a contralateral hemianopia with macular sparing, so you lose the contralateral visual field in each eye. The second thing is prosopagnosia, a fancy word that just means inability to recognize faces. So your take-home point for this short clip is subarachnoid hemorrhage can be ACOM or PCOM. Hypertension is your biggest risk factor, more so than ADPKD or Ehlers-Danlos. And a PCOM aneurysm can compress cranial nerve 3 and cause an ipsilateral blown pupil. You know the deal, team. More content on the subscribe channel. Appreciate your time. That's it.